We're going to talk about both ICD-10-CM, and we're going to throw in PCS guidelines when we deal with neoplasms. The general guidelines, the things that you need to be aware of first, is that, again, we're coding for statistical purposes. And if you've watched any of our other videos or webinars where we've talked about this, and you may have heard me talk about my mother having breast cancer, there's nothing like having somebody in your family get cancer for you to increase your knowledge base right away. So it really reiterated again to me, and again, I know I say this till I'm blue in the face, we code for statistical purposes. Why is it so important? Well, it's extremely relevant when we talk about cancer and neoplasms, because the statistics tell us whether the treatments are working or not, right? And that implements new treatments, new medications being used, policies on how the treatments are being done. Thus my mother was able to have confirmation that her malignancy was gone because of the change in protocol for the treatment for her type of breast cancer, because they started the treatment, then they did the mastectomies, and then the biopsies from the mastectomies were able to confirm that her 17-centimeter tumor was gone. There was no cancer cells. Why is that beneficial to the world? Is we know that treatment is working statistically. So it's important that we get the coding correct and we understand how the guidelines work. There are several different types of neoplasms. We have benign, which means that it's not malignant, it's not going to spread. However, don't think that benign is not problematic, because benign still grows. It just doesn't like to migrate. The cells don't go to other parts of the body. Okay. Now, if you have a benign neoplasm on your hand, well, that's not going to be that, okay, you could let that go for a while. But if you have a benign neoplasm in your brain, any little space that's being compromised there is a big deal, and you're going to have side effects. You're going to have dizziness. You're going to have pain. You're going to have, altered cognitive abilities, things like that. Then we have cancer in situ, or CIS. This is a really unique type of cancer in that it's encapsulated. And I was watching a lecture from a cancer specialist over in the UK, and he gave a fabulous description of in situ, which I'm going to share with you here in a little bit. I really appreciated the way he described it. But cancer in situ is a malignant type of cancer. It just doesn't spread. Okay. Whereas benign cancer, benign neoplasms will grow. Cancer in situ stays right where it's at. That is a positive thing, but the negative about it is the fact that if you've had cancer, if you've got cells that are acting abnormally anytime in your body, that means that you have to be very aware that you can have cells become abnormal someplace else. It can happen again. But cancer in situ is very, very specific, and you want to pay attention, because CIS, or that particular code, is a type of cancer that we need to track. Okay, malignant ultimately just means we have abnormal cells that either don't want to die when they're supposed to, they're growing too rapidly, just like benign, cancer in situ. However, malignant means it's invasive. It wants to spread. And that is the type of cancer that has to be, treated immediately, because we know that you can have a cancer in your lung, and then those cells will get through the bloodstream or through the lymphatic system and go to your brain or go to your bone, right? And then you start having lung cells grow in your brain or in the bone, which that means they can't function. The cells aren't functioning properly. We also have cancer of uncertain histologic behavior. Now, what that means, and this confuses people, it's still a neoplasm, but what they're saying is they've studied this type of cancer and they don't know which way it's going to go. Okay, so it's uncertain, which is still something that we want to pay attention to and we want to get treatment for, right? So the other thing that you need to understand about neoplasms is they're divided up with malignancy into primary and secondary. So I mentioned that we had lung cancer, and if it's invasive and it wants to travel someplace, if it travels to the brain, that's the secondary site. Primary lung, secondary brain, right? Now, that does not mean, secondary doesn't mean the second cancer that is found. Make sure you make a note of that if this is new for you. It means that there was cancer in an original site and it moved or metastasized. That's what metastasize means. It moved to the brain. Okay, it started in the lung and it moved to the brain. Can they find that in the second site first? Yes. And how they do that is if they see, say your person comes in to the ER because they had a seizure and they don't have any other reason to have a seizure. They just up and had a seizure one day. They go in, they do a CT scan, and they see that there's a mass in the brain. So they do a biopsy. They do the biopsy of the brain. They take some of the tissue and they look at it and they say, this is malignant. This is cancer. How they know that it didn't originate in the brain is it's lung tissue in the brain. So then they say, hey, this person has lung cancer and brain cancer. So they go and they look at the lungs, they do a CT of the lungs, and sure enough, they see that there's a mass or something in the lung, right? So the way we know that something has metastasized, it's that those cells that aren't supposed to be there have moved there. That's how cancer works. That's how it metastasizes. Malignant cancer works. One of the worst types of cancer for this is melanoma. And, what happens is melanoma is one of the most invasive, aggressive types of cancer. So if you have a melanoma on your hand, and it may just look like a discoloration or whatever, but the thing about melanoma is a lot of times it grows fast, but it goes down. It has a desire to go down and spread out. So it gets in the lymphatic system and the blood system very quickly, and then those little cells just all through the body. And that's why melanoma is rather scary. You got to get that taken off right away if you have a melanoma. Now, there's other types of skin cancer. We have squamous cell and stuff, but we'll talk about those in a minute. When you look up the cancer in your manual, you look at the documentation, you find out whether it's benign, malignant, primary or secondary, cancer in situ, or this uncertain histological behavior. The index has a table just for neoplasms, and all of these are covered. So you're going to go find the body site. So let's say it's lung cancer, and you can have lung cancer in different parts of your lung. It's very, very specific. It gets to a really high level. You have to know your anatomy to be able to do this properly. So let's say we have lung cancer of the lobe, and it's going to then, the table is divided up. Malignant, and then the malignant will be the first, primary. Then it'll say secondary malignancy. Then it'll say benign. Then it'll say cancer in situ, and then we'll get into this uncertain behavior. So ultimately, all you have to do is connect it. This is the code that we need to use. Then you take that code and you go to the tabular from the index, that table that you're given, and you look in the tabular for any specific guidelines that surround that type of cancer. The guidelines are based on the basic guidelines for coding neoplasms, but there's also guidelines that are specific to certain types of cancer, because statistics have taught us that if this particular cancer has these things that we need to flesh out or understand, right? So it's very important you always reference the tabular. Don't code just from the neoplasm table. Now, this is really hard for us to do because it looks like all the answers are there, right? Sometimes the code isn't even fleshed out because you may only have 4 characters there. You still need to go and get more characters. But we tend to say, oh, there it is in the neoplasm table, I'm done. No, you got to go to the tabular and make sure that there's not more information that we need to obtain. One of the things that I think new coders struggle with is that graph. So making sure that you look at the right column and then you get the right row. I think of, remember when we used to do math drills? I don't even know if they do this anymore in school, but and you had to do your multiplication tables, and then you'd write those all out in that table or that graph. And that's exactly what we're doing. We're just matching them up. But we can get to a very high specificity with the body part, the anatomy. And one of the things you might want to do is go to the neoplasm table and just peruse it, okay? It's alphabetical, more or less. So again, just look through it, go to lung, and then look at all of the types of anatomy that can actually exhibit lung cancer. Why do we have such specificity? Because we want to collect that for statistics, right? We want to know exactly what type of cancer it is. So my mother actually had 2 types of cancer. She had ductal cancer, which is really actually pretty common, and it's cancer cells that get into the milk ducts. I'll tell you, I've told you about the milk dud. My mother, after she got her diagnosis and we were driving back home, and she said, now what kind of milk dud cancer do I have? And I said, no, mother, it's milk duct cancer. So anyway, that was a funny, and I didn't mean to say milk dud cancer. So needless to say, every holiday we give her milk duds wrapped up. So that's a pretty common type of cancer, and it has specific type of treatment. But she also was HER2 positive, and that is a type of cancer that runs on hormones. The hormones feed the cancer, and that carries a different type of treatment. The regimen and the protocol is different for that. So she had 2. Some people have 1 type of cancer, and you can have 2. How do they know that? Because of the biopsies. How do they know how to treat it? Because of the statistics that you have captured as a coder, and the CPT codes or the PCS codes, the procedures that followed that they know what works. And so we want to make sure that we always reference the tabular and not just the index neoplasm table, so that we can get to the highest specificity and we get all those guidelines. It's extremely important, and you will be tested on that in probably every credential that you set for, except for maybe one that doesn't use a code set, like compliance or something. That being said, it is important to also know that when we are looking at a malignancy, they're going to want to determine what's the primary or the principal malignancy. Now, you get confused when you're looking at documentation, because let's say our person has secondary brain cancer, primary lung cancer. Well, what is the cancer that's being treated that encounter? If it is the brain cancer, okay, you're still coding, listing first the brain cancer, and then you'll also, which would be a secondary code, secondary cancer, and the primary cancer, this is the lung, and you'll list both of those when you're coding. But when you're looking at the documentation, you see that second or and you think, oh, wait a minute, what is this, the first cancer or is it the second cancer? But they're treating it, but I'm listing it first. So you can see how that gets a little confusing, but practice will make it snap for you. Again, if you're doing treatment to the secondary cancer, it's still a secondary code that indicates that it is a secondary cancer. It'll start with a C, and it'll be your next character will be a little bit higher. It'll probably be after 3 and on. But if it's, you know, a smaller number, then that's usually an indication that that's a primary listing, because it's numeric, the cancer. So it starts with malignant, then primary, then secondary, then benign. So the numbers you can almost track. You'll see that when you look at the table, and you'll notice, okay, these all start with, there's some cancers that start with a D also, but you'll see that and you'll think, oh yeah, primary is like C23, but the secondary cancer is C48, you know, something like that. You little things that you pay attention to that will also make you test faster, because if you see a cancer that's listed in the documentation as primary and it starts with a D, then it's probably not a primary code, right? Sequencing has little nuances with other conditions that are commonly associated with cancer. One of those is anemia. Now, when we code anemia generally, so a person comes into the doctor and they're diagnosed with pernicious anemia, which means that they end up having to have B12 shots, you know, to bring up their blood level. Their body isn't able to produce those red blood cells. So they give you that B12 shot, and it helps the body do that. That is a specific type of anemia. Then you have blood loss anemia, right? You're not going to have very many red blood cells if your body is spilling blood. That's a type of anemia. So there's all kinds of anemia, but anemia associated with malignancy is very unique. It is so unique that it has its own set of guidelines. And the rules for coding anemia over here, like pernicious anemia or blood loss anemia, and there's lots of different types of anemia. That's a study in and of itself if you want to go educate yourself and increase your knowledge base on anemia. That's over here. And the rules and the guidelines are very specific on how you do that. And it's pretty straightforward, and it, you know, is like all the other guidelines with other diagnoses. But when you have anemia associated with malignancy, sequencing is different. You have to look at the documentation and you have to ask yourself, are we treating the cancer and the person also has anemia, or are we actually treating the anemia and the anemia is associated to the malignancy? That changes sequencing and the rules, okay? Then you would code the principal diagnosis for the anemia. Okay, and then secondary code for the anemia in neoplastic disease. So that is a specific different type of code versus the code ranges that you'll see for pernicious anemia, for example. Now, is the anemia associated to the malignancy? Or you have to ask yourself, is the anemia being caused because of the treatment for the malignancy? Chemotherapy, immunotherapy, and radiation therapy. The fact is when you go in and have cancer treatments, it is harsh on the body. It wears out the body, okay? So chemo the purpose of chemo is to destroy cells. They focus on cancer cells, and they usually, you know, it's usually fast growing cells. That's why people that are giving chemo treatments lose their hair, because the hair is fast growing cells, and we're killing all the fast growing cells so we can kill the chemo. Excuse me, the chemo can kill the cancer cells. Now, this is extremely effective, and there's all different types of medications that are focused, chemo that's focused on different types of cancer. So for my mother, she had a specific type of chemo or medication that was given to kill the ductal cancer, and then she had there were 2 new medications that had been released 3 years prior to her getting breast cancer that was specifically targets HER2 positive cancer. Prior to that, it was a pretty rough and bad diagnosis because it's an aggressive type of cancer. But these medications had been released by the FDA and were so effective that when they went in and did the mastectomies after she'd gone through 6 months of treatment, there was no cancer cells left, no HER2 cancer cells left, which is huge. And that and again, that all falls back to the statistics that we do as coders. Isn't that amazing that we can, that they can track that? So mother never got anemia, but let's say she got anemia due to the chemo. We're killing cells. And since we're killing cells, it compromises the white blood cells and the red blood cells. And thus, it can cause anemia. Chemotherapy is a chemical that it's medication, a drug, a chemical that we're putting into the body. If we take an aspirin, we're taking a chemo. It's a chemical that we're putting into our body. But chemotherapy is associated to cancer, right? Immunotherapy is different. That's where we're building up the immune system. And a lot of times there's medications that specifically bulk up the immune system, or they may take cells from you, work on them, and then put them back in your body. That's immunotherapy. If you don't understand immunotherapy, go do a little study, write it in your notebook and say, what's the difference between chemotherapy and immunotherapy? You need to know the difference. And then, of course, radiation is, we're pretty much everybody understands chemotherapy is the drugs, radiations, we're zapping them, right? We're giving them radiation at a specific point to destroy those cells, those tumor cells. All of those can cause anemia to the body. It's harsh on the body. Now that I've given you that back history, let's say that it's documented that the anemia is specifically associated with the chemo. The patient had chemo treatments and now they have anemia. The sequencing is different than if the patient had anemia due to the malignancy, right? So let's say they have cancer of the liver. Well, the liver helps produce cells, and that would cause a person to fall into anemia. Right, so we have to know the difference. In that second scenario, the principle is the anemia, not the cancer and the chemo and all the other stuff. Secondary, you're going to code what type of cancer that they have, and there's going to be a T code that gives us the adverse effect. And then they have another little code that says it's Y84.2, which is specifically that it's the radiation causing the anemia. Now you think, why do they have all of this? For statistical purposes. We need to know the difference. Does the person have anemia due to the malignancy and where the cancer's at? Or is the anemia being caused by the treatment, the chemo, the immunotherapy, or the radiation? And then we can even break it down and say, hey, if it's radiation, we're going to append that Y code. So statistically, we can find ways to prevent the patient from getting anemia due to radiation because we're tracking that. Once you realize that, again, it's all statistical, then it these guidelines make sense. Now, besides anemia, another common thing to have happen to our cancer patients is dehydration. Dehydration is extremely common with malignancy. Now, they're not being necessarily, we still got the same thing like anemia. Are they dehydrated because of the cancer, or are they dehydrated because of the treatment? So if they're dehydrated due to the malignancy, and let's say one that might be for that is, let's say we have esophageal cancer and the person just isn't eating or drinking enough, okay, because it's difficult for them. It's due to the malignancy. Or we have any type of gastrointestinal cancer. Again, the body's not absorbing the fluid like it should. That is dehydration due to the malignancy. So if only the dehydration is being treated, so the patient has gastric cancer and they're dehydrated, they're rushed to the ER and they're going to hydrate them, and we're treating them not for the cancer, we're treating them for the dehydration. You're going to code the dehydration first and then the malignancy. They have gastric cancer. Right? That's your sequencing. What if they are dehydrated because of the treatment? Thus, usually chemo, because chemo will make you very nauseous, nausea, and vomiting. We're poisoning the body. We're poisoning the cells of the body. And radiation, not so much. It can happen, but even immunotherapy can make you have nausea and vomiting. Okay, because we're we've taken stuff out of the body, and we're reintroducing something to the body. And the body is, wonderfully made, and everything works copacetically all together. Whenever you do anything to change that, then the body's going to have a reaction. If we are treating the dehydration and it's a result of a complication from, say, a surgical procedure, then we're going to put the complication first, and then we're going to talk about the treatment and resolving the complication. So the sequencing, again, changes a little bit. What happens if we have our primary lung cancer? Let's talk about our patient that has lung cancer. The secondary cancer is the brain, so we'll just use that scenario. Let's give that person a name. Let's say we had Mr. Green in previous lectures, right? And he had the pneumonia and he had the diabetic foot ulcer. So let's say this is Mrs. Brown. Mrs. Brown has primary lung cancer, secondary brain cancer. And they excise the lung cancer, right? There is no more lung cancer. There's still brain cancer. This was the primary cancer. You're still always going to code the brain cancer as secondary. Doesn't even matter if the other cancer is resolved, excised, they're not getting treatments of anymore. This will always be the primary cancer because that's what it was designated as. The brain cancer will always be secondary cancer when you code it, even if this is the only treatment that the person is given. And timeline doesn't matter either. So we have Mrs. Brown gets lung cancer. Let's say in the year 2000, it's treated, excised, and she no longer has it. 2005, they find brain cancer. It's secondary. Okay, they find that it's secondary to the lung cancer, not a new primary, and that can happen too. It doesn't happen very often, but it can happen. So this is lung cancer moved to the brain. From that point on, it's always coded as secondary, even though we're not doing any treatment to the lung. We're only doing treatment to the brain. If this cancer is excised, it's a history. There is a specific code for a history of. There is specific rules for you to be able to call that a history of. It states that it has to be gone. There is no extension, invasion, metastasis to any other site. Okay. Well, no, let me take that back. Primary malignancy, if it's a history of, that means that you are no longer treating it, right? They've gotten rid of it. Can it come back? Absolutely, it can come back, but it'll be classified as a history from that point on until the documentation changes. And any mention of any invasion or metastasize becomes that secondary site and will always be coded as a secondary site. And then if it goes to the bone, also that's a secondary site as well. So breast cancer, lung cancer to brain cancer to bone cancer, it's still primary, secondary, secondary. When we admit a person that is getting chemotherapy, immunotherapy, or radiation, and from this point on, I'm just going to say treatment for their cancer. Okay, so that means one of the three. And we are treating the surgical removal of the neoplasm. So we need to go in and take out that neoplasm, that tumor of the brain. And then we're going to do chemo and radiation during the same episode of care. How do we code that? We code it with the neoplasm first. And if it's the brain cancer, it's a secondary brain cancer code. Right? Am I your head yet? Don't worry, you're going to get lots of practice in this. You can come back and review this as we go. Then let's say we've got a patient that's seen solely to have their chemo or their treatment. Okay. How do we do that? Well, we're going to code encounter codes. Why are they being seen? That's what you're always asking. Why are they being seen? Well, because we're going to give them radiation therapy, or we're going to give them chemotherapy, or we're going to give them immunotherapy. All those are different codes. You're not going to do all of those at one time. They don't do radiation and chemo at the same time. Usually, as a general rule, the body can't handle that much trauma, actually. I think they can do chemo and immunotherapy at the same time. You'd have to look at that and see. But there are specific codes, Z code. They start with a Z, and they say, why is the patient being seen? They're being seen. The encounter is for immunotherapy. All right. So that's what you code. And then the malignancy is, why are they being treated? It's an encounter for chemotherapy, and it's secondary brain cancer, or it's immunotherapy, secondary bone cancer, or it's radiation therapy, and it's primary cancer of the lung. Okay, that makes sense. So don't let primary, secondary, first, second, all of that stuff. You have to go back and see what it's related to, what it's being assigned to, those terms. But always know the key is, why is the patient being seen that day? What treatment is being done? Now, if they are doing more than one therapy, say they're doing radiation and immunotherapy at the same time, what do you list first? The radiation therapy or the immunotherapy? It doesn't really matter. But you're going to list both of them because we need to know statistically the treatment that's being done. Also, statistically, we would be able to abstract that and tell, does immuno and radiation therapy work together at the same time, or should it be spread out? Right? So think of all the possibilities out there, the reasons why we code for statistics so that we can treat the disease process better. All right, now we're going to talk about if we have the person being seen for one of the therapies and they're coming in for the therapy, but they develop a complication. So then how do we code? Well, we need to list first the encounter for why they're being seen. They're being seen for chemotherapy, and then the complication. Their blood pressure bottoms out. That's a complication. Their blood pressure was fine when they started the chemo, and then 2 hours in, their blood pressure bottoms out. That's a complication. So the encounter, why were we seeing the patient? We're giving them chemo, and what happened? Oh, they got hypotension, and then you'll be able to code out what you did or whatever. So that's the reason. Why are they being seen? They're not being seen because of the hypotension. That's a complication. They're being seen for the treatment. They had a complication, and that's coded second. And then you'd ultimately code what type of cancer, because why are they getting the chemo in the first place? You got to tell the whole story. There's also a reason to come in there for, we got to determine the extent of the malignancy. That means that you would code the primary malignancy, and then if there was a secondary malignancy. So we're going in to, we know that the patient has, Mrs. Brown has lung cancer, and she's exhibiting signs and symptoms of having problems with her brain. Maybe she comes in with a seizure. So is her seizure related to the treatment that she's getting? Maybe the chemo? Is it related to nothing? Maybe she just got dehydrated and she had a seizure. Sometimes that's just the body's way of reacting to trauma, is having a seizure or fainting or something like that. So they've got to determine that. Is the heart, some chemo medications are very hard on the heart, and so could it be not a seizure, but actually something that appeared to be a seizure, but it was to do with the heart, like AFib or something like that, or has it metastasized to the brain? So why are they being seen? To see the extent of the malignancy. So we're going to go see if this is related to the brain, and we're going to do an MRI and do some blood draws, et cetera, et cetera. So the primary cancer is still the principal diagnosis in those incidences. We also get signs and symptoms in Chapter 19 that are associated with malignancies. Now, I don't usually say Chapter 19, quite honestly. I just say what the code starts with. But they, you know, for you learning where to go look for that, you'd go to chapter 19. So what happens when we have some signs and symptoms, or we have abnormal findings? An abnormal finding would be blood level, labs being abnormal, or going in and doing a CT scan and seeing a mass. That would be an abnormal finding. You cannot use that to replace the malignancy as the diagnosis, as a principal diagnosis. It doesn't matter how many times the patient is being seen. Why are they being seen? They had brain cancer. Okay, but if the patient is being seen for pain control due to the malignancy in the brain, there are specific guidelines that follow that. So you want to reference the guideline table, the guidelines at the front of your manual, or when you get to that code, and it'll say code also, see code in addition, et cetera, et cetera. That's why you always have to go to the tabular. Can't just code off the index. Oh, now we're going to talk about malignancy, and we have 2 or more continuous sites. What does that mean? Well, ultimately, you have a tumor and it's 2 different primaries. Now, how would we know it was 2 different primaries? Because if Mrs. Brown has lung cancer and it moves to the brain, then we have lung cells in our brain. What if Mrs. Brown has lung cancer, okay, and then they go in and they do the biopsy of the brain, and that isn't lung cells, it's brain cells that have gone crazy, right? That's 2 primary cancers. How did they know that? They did a biopsy and actually looked at the cells. Now you know primary cancer that metastasizes likes to go someplace else. How do they know it's a secondary cancer? They look at the cells. If they go look at the cells and nope, those are all brain cells. There's not cells from anything else. These are brain cells that went off the wagon. Then you have 2 different primary sites. How do you sequence that? Well, you sequence it based on what the patient's being treated for that day. And you can have 2 primary sites. Is that common? In my experience, I don't see that very often. However, if you work with tumor registry or doing oncology full time, you're probably going to be exposed to that much more. Can it happen? Absolutely, it can happen. And how do we know the difference? Because of the documentation. How do we want to make sure, or why do we want to make sure we get that coded correctly? For statistical purposes. You know, is it lung cancer that went to the brain, or is the body just so out of whack that we have brain cancer and lung cancer happening at the same time? Okay, and it's malignant because of the type of cells that it is, that it's cells that they know want to move and metastasize versus benign or in situ. If you don't know, if it's not documented, then you're going to have to query the provider. And you're going to have to say, when Mrs. Brown came in, I know she's being treated for primary lung cancer. We did the biopsy of the brain. I'm looking at the pathology report, and the pathology report came back as a primary malignancy. Does that mean this is a new cancer, or is it a metastatic cancer that moved, a new malignancy? And for the most part, the provider is going to be very specific. If you don't have any documentation that separates those, it's going to be primary and secondary. But if you were to read that path report and you're thinking, hey, I wonder, do we need this? We need to document this at a higher specificity. Then query the provider. And I always say there's a specific way to query the provider. We're not going to talk about that now because that's a education in and of itself. Make a note to yourself in your notebook and say, you know, understand how to query a provider, because you will be tested on that. You know, they have to be open-ended questions. You can't lead the provider in any way. And ultimately what you're doing is you're saying to the provider, you're saying, hey, doc, I'm looking at the documentation. I want to get to the highest specificity. Please educate me in what you're saying here so that I make sure that I capture the codes correctly. Ultimately, that's the way we query. And then you'll be able to get to the highest specificity because we want to do that for statistical purpose. Remember, you're that liaison so that you're telling the provider, say, hey, there's guidelines here and options, and I want to get to the highest specificity because I want to translate the correct code for you. There is also a type of malignant neoplasm that's called decimated. And whenever you have a decimated malignant neoplasm, that is, again, a very specific type of cancer. And it means that the metastasis, the cancer, is so prevalent, they can't even tell if it's primary or secondary at this point anymore. Okay, and it's called decimated malignancy. And there is specifications that happen with that. You are not going to ever use that unless it's documented, decimated, and they'll use that term, decimated. And that is, in layman's term, have you heard people say, oh, Mr. Jones has cancer. I heard Mr. Jones had cancer. And someone says, yeah, I heard that too. He's full of cancer all over. He's only got like a month left. That's kind of what they're talking about, in layman's terms. What happens if we have a malignancy, but we don't have a specific site? What do? There is a code for having a malignancy, a primary malignancy unspecified, but that is not going to be used very often. When would be times that you might use this? If your patient is a poor historian, not able to articulate and tell you, if Mrs. Brown comes in and they know that she has bone cancer and brain cancer because she tells you that, but she doesn't know primary, secondary, she doesn't know, and you don't have the documentation for any of that yet at that point, then there is a specification for that. Now, if it's an inpatient, eventually you're going to have that information because the records will get to you. Okay, but there is a use for this unspecified code, but it tends to be a little rare. But it is there to be used, and they will test you to see if you know that that code is available to you. But again, by the time the patient is an inpatient, you're going to see this in, maybe outpatient, or you're going to see this in the ER trauma centers where a patient comes in and they just don't have that information coming to them. Maybe the patient's traveled for whatever reason. When we look at sequencing, again, let's backtrack a little bit. What is the patient being seen for? If they're being treated for the primary malignancy, that's the principal diagnosis, meaning that's first listed. If the primary site if the primary site is sequenced first, then you list all the places that the metastatic site or sites. Mrs. Brown has lung cancer. That's the primary site. It may not have been the first site that the cancer that they found, but that's the original site. They know that because of the lung cells in the brain. And the brain cancer is going to be secondary, and that's the way it'll be coded out. Primary, secondary from that point forward, unless the encounter is to treat the brain cancer. And then you'll flip the codes. But the code will still be a secondary code. Thus, secondary malignancy, if that is the only site that's being treated, then again, the secondary site gets coded first. Now, if a person is coming in and has chemo, and they have, Mrs. Brown has lung and brain cancer, which are you going to sequence first? Well, the chemo is for both. So you'll sequence the primary cancer first, and then the secondary cancer. If, again, it's the brain cancer that's being treated because it's radiation therapy, then we're going to sequence the secondary code first. What happens, let's throw something else in there. What happens if you have a patient that's pregnant and has a malignancy? Well, everything changes for pregnancy. Pregnancy is its own little world, okay, over there in the O codes. So we would code everything just like we normally had, but all the rules apply, except if you have it, the cancer is complicating the pregnancy, the childbirth, or aftercare, puerperium. Okay, then that'll be sequenced first, and then the cancer will be second, because it's all about why the patient's being seen. Is it complicating the pregnancy? Then the complication is first, and it's probably going to be an O code, and then the neoplasm next. If again, don't forget, there's always exceptions to the rule when you have anemia. Okay, we already covered that though. We talked about that. Our patient goes in to have a surgical procedure and they have a complication. They're having the surgical procedure due to the cancer. So Mrs. Brown goes in to have the tumor removed from the brain as much as they can, and there's a complication. Then you list the complication in the procedure first, and then the cancer. Another thing that happens with patients that have cancer is fractures, pathological fractures. Now, it is true that cancer weakens the body, but cancer doesn't, just overall cancer doesn't necessarily weaken the bones per se, the chemo treatments and things like, not necessarily, but there are specific types of cancers that weaken the bone, like bone cancer. Okay, so a pathological fracture means that ultimately, if a patient is walking across their kitchen floor and they trip and fall and they fracture their femur. Now, you or I walking across the kitchen floor and we fall, we are not going to fracture our femur. The femur is the strongest bone in the body. You know, it just doesn't happen. There has to be massive trauma to fracture a femur. So what caused the weakness in the bone that allowed this fracture? If it's pathological, it's a disease process. Something happened. And you see this with osteoporosis. A patient has severe osteoporosis, and they can fracture hips and their neck and stuff like that, or their femur. But it could also be bone cancer. So that would be classified as a pathological fracture. The fracture would not have occurred normally unless there was a disease process involved pathologically. How do we deal with that? We have to statistically show that. So if the focus is on the fracture, okay, Mrs. Brown, remember, she has lung cancer, brain cancer, now she has bone cancer, and she broke her femur. That's a pathological fracture that's documented. So you can use M84.5, which is sequenced first, then the bone cancer will be sequenced, the neoplasm, thus all the other cancers that she has too. Because M84.5, go look at that code. That code states that it is a pathological fracture due to the cancer. If you're having treatment for the neoplasm and they have a pathological fracture, then the sequencing is different. Why are they being seen? We're giving them chemo. Oh, they're getting chemo, but they also have a fractured femur. Then the M84.5 is sequenced after the cancer, because why are they being seen? They're not being seen for the fracture. They're being seen for their treatment for the malignancy. Now, let's go back to current malignancy and personal history of malignancy. I already commented on that a little bit. When your guidelines for that is saying if the malignancy has been excised and they are still having treatment to that site. So we removed Mrs. Brown's brain tumor, okay? There is, you know, that tumor's gone, However, she's now getting radiation. That's still active treatment. That is not a history of. She's still getting radiation. So you can use that as the primary code. Even though the tumor is out, she's getting radiation. If you have the primary malignancy is excised, there's no more treatment to the site, there's no evidence of that cancer anymore, then you can use the Z85 code indicating it's a history of. Now, let's go back and say, Mrs. Brown, we excised, we actually removed the lung. Okay, we removed the lung. She has the other lung, but it's free of disease. That, and she's not getting any treatment. She's gone through all of her chemo and everything, because we're in that, remember we said lung cancer 2000, and they don't find the brain cancer until 2005. So she's going and she's getting treated and everything. And it's 2003. And how is she going to be coded? She's a Z85. History of lung cancer. Good, there's no more cancer there. Okay. She comes in 2005, they find the brain cancer. That's a secondary cancer, and she's a Z85. There's no cancer left here in the lung. Right. The only time that changes is if the lung cancer would come back to the other lung, and then as a primary, and then you would remove the Z85. You can't remove both lungs. Yeah. Leukemia can have in remission versus personal history. The thing about cancer, there's some studies that'll tell you cancer doesn't really ever leave you. You don't cure cancer, because they can never be 100% sure that those cells are not floating around in the body somewhere and won't come back and metastasize someplace else, or adhere someplace else. So, but you don't tell patients that. You don't say, hey, your breast cancer is all gone because you've had a bilateral mastectomy. We found nothing in the biopsies. I mean, you can't tell my mother that her cancer, she's cancer free, because even though there was no cancer cells in the lymph nodes and everything, technically there could be cells floating around in her system, and they could adhere someplace else. That's why patients, even if they're a history of, they go and they have checks done throughout their life. After your body has made cancer cells, it's primed to do it again. May never happen again, but if it does, we know that's ultimately what happened. Those cells finally stuck someplace. Leukemia is a little bit different, okay, because they use the term remission. Leukemia is a blood cancer. The body is not making white blood cells. So you would use remission versus a personal history of leukemia. There's two separate things there. So if you have leukemia and multiple myeloma categories, they have a code for remission, and that it will state the patient's in remission. There is not a code for remission of leukemia, history of, and sometimes, though, that documentation is a little hard to follow. So again, that's where you're going to query the provider, to find out, is this leukemia in remission or active treatment? If you have a neoplasm that is the result of a transplanted organ, that's considered a complication of the transplant. That's different codes. That means you're going to end up with a T86 code, and then you'll have a C80.2. So go look at those two codes. Make a note in your notebook to go and read the guidelines surrounding those codes. And then you'll have codes for a specific type of malignancy. When would this happen? Well, if a person had a kidney transplant and then developed cancer in that kidney, that can happen. Okay. Let's see. If we do any aftercare for surgery of that neoplasm or that cancer, there's Z codes involved with that. Again, why are they being seen? For aftercare. And that means you have to understand what aftercare is versus sequela, et cetera, et cetera. And we've talked about that already in previous lectures. Most of the time that's going to be listed first, but with the treatment after that. But make sure that when a patient's coming in for follow-ups, that there's no evidence that the cancer has come back, okay? Because that would change your history code. Okay, so follow-up due to a history of breast cancer. You can have that. And again, if we look at a neoplasm that develops with a transplanted organ, then the primary is that complication, and then the secondary is the malignancy. What about neoplasms that result in pain? That can be classified as either acute or chronic. So I want you to go look at G89.3. This is a specific pain code that's related to the neoplasm. You're going to use code 89.3, but if the reason for the encounter is the treatment for the pain resulting in the neoplasm, then you get to code the G code first. And then the secondary code will be the neoplasm. However, if it is just management of the neoplasm and pain, the cancer gets coded first. And then the pain, the G89.3. So make a little note for yourself in your notebook, G89.3, and make sure that you understand the sequencing guidelines that surround that code. And they're listed right there. You don't have to have this stuff memorized. It's right there in the code. And sometimes, you know, you just have to know that these codes exist, right? Then you can follow the guidelines. Well, whenever we're dealing with cancer, it is very important that we understand the anatomy and the physiology of the body and neoplasms. So at this point, if you don't have that understanding, then you need to backtrack a little bit. And, you know, like I said, I say often you need to know the bones, because so much of the anatomy is described or named after bones because it's locational. And you need to know your major organs. You need to know the chambers of the heart and so on and so forth. Do you need to know all of the parts of the brain? Not necessarily, unless you go into neurology. You know, do you need to know all the individual little bones of the hand? No, you don't. But you need to know those are carpals and metacarpals and phalanges. Okay, unless you go into orthopedics, then you may want to know what the name of all those little square bones are. It's so important when you're dealing with cancer that you understand the anatomy of the body as well as the physiology. Now, because of the statistics that they've been able to collect due to our translating these into codes, we can tell what cancers like to go to metastasize to what parts of the body. And that's an easy list to go find. Just go Google how common, let's see, common cancer metastasis. I think, you know, that might be how you Google it. Or maybe even where does brain cancer like to metastasize? Just Google something like that, and it'll tell you. So if a person gets brain cancer, it'll tell you where the most common statistically, you know, that like lung cancer likes to move to the brain and the bone, or breast cancer likes to move to the bone, you know, into the lung or whatever. Now, don't quote me because I can't remember that. I used to know that really, really well. I used to have them memorized predominantly, but I don't deal in that like I used to. So I don't want to tell you. Take that with a grain of salt. But we know statistically what is common. And we know, again, they know what cancer that my mother could develop after her two types of breast cancer because of statistics. And that means that if she ever has specific pains in her bones and stuff like that, she's definitely going to go in and find out, is that pain of the bone, or is that like a neuropathy as a result of the chemo that she ended up having, things like that, or is it just arthritis because of her age? Whenever we have a neoplasm, any type of cancer, whether benign or not, it can affect the whole body systems. You know, so if we have a gastric cancer, it's going to affect the gastrointestinal system. We need to be aware of how the body works whenever you're dealing with neoplasms, because then we can identify when something's out of the norm. You can go to the National Cancer Institute, and they can tell you what the most common cancers are. They can tell you what the most common cancers are for women versus men. They can tell you the cancers that are more common via age. And that's how we know that the brackets gene for women, if you carry the brackets gene, that your statistics are more than like doubled in the reality that you'll probably have breast cancer. And that's why you have women that'll go in and have bilateral mastectomies, because they carry the brackets gene. So they'll just have the anatomy removed. If you knew that you were going to get a specific type of cancer, you'd go in and remove that organ if it was a possibility to prevent it, right? The most common cancers, statistically, we know that because of the coding that we did, are colon and rectum, kidney, which would be renal cell, by the way, lung, pancreatic, skin, which is non-melanoma. Now, melanoma is skin cancer, but non-melanoma are going to be like squamous cell and basal cell carcinoma. Very, very common. They're benign, but they still have to be removed because they grow and cause problems. I've seen tumors of people that have had non-melanoma, squamous cell carcinomas, and they're this big on the face. That's going to be problematic, right? And non-Hodgkin's lymphoma is pretty common. So there's non-Hodgkin's lymphoma and there's Hodgkin's lymphoma. If you want to increase your knowledge base, go and see what the differences are in those two. And there's age differences, and there's also female and male versus for both of those. One of them affects children more than adults. So it would be an interesting study to go look at that. Going back to the anatomy, and I already really kind of covered this, a neoplasm is just the cells are abnormal. And every cell in our body, it grows, it rejuvenates itself, not rejuvenates, I take that back. It creates, it has a timeline for creation, for new cells, life expectancy of a cell, the way that it dies, and what happens to the cell once it dies, how the body rids itself of that. Whenever you have anything abnormal in that timeline, then it can turn into a neoplasm. Different things can cause that. That's why we know the carcinogen of smoking promotes lung cancer, because it's an irritant. So think of it this way. If you sit there for an hour and do this, not even if it's not painful at first, you just do this for 1 hour, same spot repetitively, what's going to happen? You're going to wear down the tissue of that area, and it's going to hurt, and it's going to end up breaking down the skin there, a repetitive movement like that, and it is going to cause a scab. The body heals itself, okay? Now, what happens if you did that for a week, not just an hour or two? You did this for a week, and you didn't allow the scab to build up. What's going to happen? Pretty soon, it's going to traumatize those cells in a way that it could eventually cause scar tissue, right? The body isn't able to heal itself properly, and now you're not just getting a scab, you're getting scar tissue. So it's an irritant. Even if I'm just rubbing smoothly, it's going to irritate the skin because it's abnormal for that exposure to have happen. Thus, smoking, irritant to the skin. There are all kinds of carcinogens or things out there that cause our body to react abnormally. Long-time exposure can do it. It could be a one-time exposure that messes with the cells. Ultimately, what happens is the cells do not create, live, and die properly, okay? Or they mutate. So instead of that you can look at normal cells, and you can see a slide of normal cells. There'll be nice little round cells with a little dark, say a little purple circle with a dark purple circle in the middle of that cell. And then you'll see like 5 of them in a row. Okay. And they split, and they make, when they get ready, when this one's, at a certain point in its life, it'll split and make two that replaces that one, and then that one will die and go away. Okay, and that's how the cells work. So let's say out of those 5, you have those perfect little circles, and then you get this one on the end, and he is not a perfect little circle anymore. He's oval. Right. Well, not such a big deal, right? But he splits and makes 2 more oval cells instead of circle cells. And then he splits and makes 4 oval cells. Pretty soon, one of those cells isn't an oval anymore. He turns into a square. Well, his job, he can't fulfill the function that he was designed as a square like he could when he was a circle. Okay, and now he's replicating himself, making squares instead of circles. And then, now let's say he starts replicating himself double time. So you got all these circles, perfect little nice cells, and now you've got this square cell making double time. So for every 2, he's making 4 instead of 2. Boom, 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 boom in the timeline. So again, that's ultimately kind of how cancer cells work. And they find a wonky way. And then he decides, hey, I'm having so much fun. I'm going to go someplace else in the body. I'm going to break off and go over here and start making square cells over here. The difference, again, between benign and malignant is if I'm going to start making square cells over here rapidly, that's one thing. But if I'm going to move, that's malignant. Now, can you move and not make cells someplace else? Yeah, you can break off, but they know statistically, they can look at a cell and say, yep, we recognize that cell. Don't think that this is new to us. We've seen these square cells before, and we know that they don't like to go anyplace else because we recognize that cell. We've studied it so long. This is a benign tumor. However, it grows very rapidly, and so we need to get rid of it because it's going to compromise the area. It's going to take over. So we're going to take out all those little square cells so they quit replicating themselves and leave more room for the nice little conforming circle cells. We can have fibromas, which end up being like connective tissue that goes crazy. And then we have melanomas, which they are abnormal growth of melanin cells, which are in the skin, and it's very invasive and aggressive. Okay. You can, if a person has a confirmed melanoma, whenever you see the initial treatment for that, they are going to take a large area. A person that was an acquaintance of mine, I made a comment about a scar that she had on her leg. And I said, what happened? And she said it was a melanoma. And she said, and that melanoma was only like this big, not even the size of a quarter. And her scar was like this long up her leg because they went in and they took all of that tissue to make sure they had clean margins, which is another whole thing to talk about with cancer. So melanoma is very aggressive. Carcinomas are malignant and they are epithelial cells. Okay. If you have adenocarcinoma, that is malignancy of the epithelial glandular tissue. So wherever you have a gland, it can cause malignancy, and they will find that glandular tissue in the brain or someplace else. It likes to go to the brain and the bone. Sarcomas are connective tissue. Now, see how important it is to know the anatomy of the body? We have to know what an epithelial cell is. We need to know what the glands are in the body. We need to know what the connective tissue is. Lymphomas are lymphatic tissue. Think of your lymph nodes. Your lymph nodes parallel your vascular system. So wherever there's blood vessels, there's probably lymphatic vessels, and they're tubular. They're like rivers running through your body, and it helps expel waste from our blood. So again, why do they always take lymph nodes around where they find cancer? They want to see if those cancer cells have broken away from the breast and gone into the lymphatic system. If they find any of those breast cancer cells in those lymph nodes, they're going to go in and take more lymph nodes. They're going to take a strand of lymph nodes. So lymph nodes end up growing like, think of a grapevine, and you you know how you go and you get grapes at the grocery store and you pull out that bag, that thing, that stem of grapes. Okay, so you have the basic structure, and then you have all of those little grapes that are hanging off of it, right? So a strand or a strain of those is, you break one of those off and you eat the 5 grapes that are on there. So that's what they do. They'll go in and they'll take like they'll pull out of that bag, they'll look at all those grapes, and they'll take a grape from over here and a grape from over here and a grape from over here, and then they'll go biopsy it. And if they find that any of those have cancer cells, they'll go in and they'll take more of them, okay, to make sure, hey, did it go anywhere else? And that's lymphoma, lymphatic cancer. Leukemias are blood, white blood cells, and myeloma is bone marrow. So you have cancer of the bone, and it's in the bone marrow. When you have a primary site, that's where the cancer originated, and it metastasizes and spreads to another part of the body. How does it spread? Usually through the lymphatic system or the blood. Now, there is grading of cancer, and you've probably heard this. If you want to get more information, go study some tumor registry sites. They're great. Now, that is a different type of coding. We code for statistical purposes, and we say statistics, right? They put all that data in for statistical purposes in a registry, specifically registering tumors. And it's done on a much higher level, okay? So the regular grading of cancer that you're going to see in the documentation is they want to know how aggressive the cancer is. And there's guidelines, there's like a protocol. And so this grading will be based on the more abnormal the cells are. So they go in and they do a biopsy. And you remember those little circle cells and those square cells? So we have circle and square cells, okay? If you just have like 4 square cells, that's a lower level than if you have 20 when they do a biopsy, okay? It would have a higher grade. Differentiated, so let's talk about the square cells and the circle cells. So they go in and they see the circle cells and they see ovals. Well, that's really close to a circle, right? A little egg shape. It's not quite a circle, so it's abnormal. But circle cells and square cells, specifically different. That's well differentiated or undifferentiated. They're really abnormal. So you could have a grade 1 or a grade level 4. So if you have circle and ovals, that's a grade 1. But if you have circles and squares, that's a higher grade. If you have circles and triangles, that's really weird, because, you know, even with a square, you're kind of, you know, you've got 4 points, but 3, you know, we don't even look like a circle anymore. So that would be a higher grade. And again, I'm simplifying this greatly just so that we can get an understanding of how to do that. If we are going to also look at the staging. Now, staging, the other things that we're going to look at is what stage they are will tell us what treatment that they need. So my mother's breast cancer, even though she had 2 types of cancer and one was a pretty aggressive cancer, there was no cancer in her lymph nodes, there was no cancer in her other breast. Okay, so, and she had no signs and symptoms of any other type of cancer. So her staging was pretty low, except for the fact that it was 17 centimeters. Now that's a pretty large cancer cell, you know, a tumor. So that made it go up a little bit, but it went down again because there was nothing in the lymph nodes. So that's good. You know, so she ended up, it's kind of like a science to get that staging. You got to put all the factors in. So she did not end up having to have radiation because of the treatment that was designed, and there was no cancer found in the mastectomies after she'd gone through her initial treatment, and there was no cancer found in the lymph nodes at the time. So again, that resulted in the treatment, no further therapy. She could have gone and had radiation, or she didn't have to, because statistics told the radiologist that spoke with her, that he said, you know, our statistics show that your chance of getting the cancer back is no greater if you have radiation or not. So why put your body through the radiation, in my opinion? And we agree. So if you have stage 1, that means the cancer has not spread, it's localized, it stayed right there. So my mother had stage 1 there. Had it spread to surrounding tissue, but not past the origin, it would be stage 2. Okay. If you have stage 3, that means it's regional, it's spread, and it's gone into the lymph nodes. If you have stage 4, that means the cancer has spread to other parts of the body. But thus, Mrs. Brown has lung cancer and it's spread to the brain. If she had Mrs. Brown, probably, if they went and they did lung cancer and they checked the lymph nodes around the lung, they would most likely find that there were cancer cells in the lymph nodes because they found it in the brain. With the neoplasm table, oh, and two, I'm not sure, I can't remember if the slides tell us, other things have to do with regional, they cut the body at the diaphragm. Is the cancer, so if the cancer stayed if you had renal cancer and then you also had lung cancer, that's 2 separate parts of the body. Okay, because we cut it at the diaphragm. If you have lung cancer and brain cancer, you stayed at the upper part of the body. So that changes staging. Okay, that makes sense. If you have brain cancer and you have uterine cancer, the body's divided. That's 2 separate parts of the body. That means that your staging is going to is a higher staging because it went from one end of the body to the other end of the body. That's another thing that they do with staging. But again, when we do this for coding purposes, we look at the staging, and it doesn't really per se make a lot of difference in our codes unless the codes specify that in the tabular, and sometimes, and it will eventually do that, but that will be stuff that statistically is being captured with the tumor registry. So once we've established that the code and the statistics are set for the patient having a specific type of cancer, primary, secondary, the tumor registry is what really differentiates the treatments and so on and so forth. So we're that first contact, and then the tumor registry lets you get to an extremely high specificity that we aren't able to get to. And it's really quite fascinating. That is something that, if this is interesting to you, you may look into. There's education and certifications for tumor registry, and that would be excellent to have both of those if that is something that you want to get into. So again, the neoplasm table, we look at the neoplasm table first. We find out where our location is, and if it's where we are in the columns, malignant versus benign, primary, secondary, uncertain behavior, cancer in situ, et cetera, then we go to the tabular, and we get all of the additional information that we list. I pretty much have gone over this with you already, but just some things to reiterate. If you go into lung cancer, like I said before, there is going to be a whole list of all the specific types of lung cancer that you can get. It's based on the anatomy of the lung itself. Where you're going to see this prevalently will be organs, larger organs. You'll find this in the kidney, renal cell, because the anatomy of the kidney. You also find this pretty prevalently in uterine cancer. Where is the cancer at? In the uterus, because that's all defined, as well as ovarian cancer. You can have cervical cancer. You can have cancer of the fallopian tube. So all of that anatomy is very, very specific. And then other places, let me think real quick, other places that would be specific, the types of skin cancer. But as you go through the neoplasm table, if you come up with a term, you think, hey, I don't know where that is. The digestive tract, think of all of the different names of the digestive tract, from the cecum to the colon to the jejunum. You can have cancer in every one of those places individually. It could be in the jejunum and not in the cecum, et cetera, et cetera. Different parts of the stomach. Is it pyloric? you know, or not. So again, knowing the anatomy is very important because you're going to locate it by site in the neoplasm table and then look at the subterms and always go to the tabular. Oh, well, cancer that likes to spread. Well, this is pretty interesting. Spreads, this is just kind of a heads up. If you don't know what the meninges are, you need to know what that is because that's in your brain. Spinal cord, this is just telling you likely organs that cancer spreads to include these here. They're not saying bone spreads to the brain. They're just saying these are all the cancers that if a person gets these type of cancers, they like to spread. Now, then you can go look at the bone cancer and say, where does bone cancer spread to? And statistically, and because of what we code and the tumor registry, we can tell where it likes to spread. And you can even see both men and women. Subcategory 8 per guidelines if you have continuous sites. So that means there's a specific code for we have cancer of the lung that encompasses the entire lung. Okay, so continuous sites. You'll see this very much in breast cancer because the breast cancer has been studied so much that we used to just have the breast divided up into quadrants. Now it's even levels of quadrants and everything, so it's extremely specific, and that's pretty cool. You know, there's so much study going on with breast cancer. And you know what is really interesting, because breast cancer is not one of the more common cancers. We just hear about it more. You know, so when you looked at the common breast cancers, breast cancer is not. Colon cancer is much higher than breast cancer, and yet we don't study colon cancer as much as we do breast cancer. But the good thing about this is that because it's been studied and we know it's so common, colonoscopies are preventative. We go in and we know, you know, when you reach 50, you need to go in and have a colonoscopy screening or prophylactic colonoscopy, preventative medicine. And same thing with mammograms. And your insurance will pay for these things because it's cheaper to identify colon cancer very quickly, or abnormalities in the colon like polyps and stuff like that, as well as mammograms to get it early. So for me and my sister, it's very important that because our mother had breast cancer, let alone 2 types of breast cancer in the one breast, that we go and get a mammogram. So that if, because my mother had had a mammogram 3 years prior to the one that they found a 17-centimeter tumor in. So can you imagine, in 3 years, a negative mammogram? 3 years later, she had a 17-centimeter malignancy. So again, that's why we know for statistics and you know, why we do this. Now, continuous sites means that the malignancy has spread throughout the entire breast or the entire lung or the brain. It overlaps what we've designated as specific categories. And there's a specific code. It's going to be, let's say you have C32 point cancer, whatever that is. And I can't remember. I think it's esophageal laryngeal cancer of some type. And if it's continuous overlapping sites, it'll be a 0.8, just so you know. Make a note of that. Whenever you have a 0.8 cancer, whether it's primary or secondary, that's an indication in your brain it's a overlapping. What will that help you with? That'll make you a faster coder, but it will also make it good for your testing, right? A 0.8 cancer is going to be overlapping sites. So if you see that in the documentation, boom, help you rule out. We need to be able to identify neoplastic diseases. So think of things like lip, oral cavity, and pharynx. Those are all oral cancers, okay? Because the beryllium is the little line, you know, where you put your lipstick on and you put your, when you get to be a certain age, like I am, your lipstick bleeds a little bit. So you put lip liner on to hold that lipstick in place. Well, where you put that is called the beryllium. That's the little outline of your lip. You can get cancer of the beryllium, not only just the lip, the oral cavity, any place in the mouth, or the pharynx, back behind the nose and above the tonsils, the pharynx. 90% of those oral cancers are squamous cell carcinoma. Squamous cell carcinoma is benign, but how small is this area, right? If you get a squamous cell carcinoma right here, and it just keeps growing, what are you going to have? You're going to have a big old giant mole sticking on your face, right? It's cancer. And certain types of squamous cell carcinomas can eventually turn into cancer. So just because it's benign, you want to get that taken off. You don't usually find stuff like that until they've spread or gotten big enough that they cause a problem, especially in the pharynx. We're just going to think that the reason our nose feels stuffed up all the time is because we have allergies, that irritation, right? We don't go looking up our nose now. If we got something on our lip, you bet we're going to identify that. But in the oral cavity and the pharynx, we're not going to see that until it gets big enough to be a problem. Smoking, 70–80% of all cases are associated to oral cancer. And did you know heavy alcohol use causes cancer, makes your risk of cancer getting higher? Lip and tongue cancer is the most common type of oral cancer. One of my friends, her husband ended up getting oral cancer, and then it ended up getting esophageal cancer. And then another friend of ours ended up having cancer of the tongue, and he was a very heavy smoker, and he was a very heavy drinker. So, again, it progressed, and he succumbed to that about this last month. So that statistically, how do we know those statistics? We know them because of the coding that you've done, and you will be doing. And then that coding initiates the tumor registry that gives us even higher specifics about it. Digestive organs, that would be colorectal and liver cancer is considered part of the digestive system. Primarily, it happens to people that are over 50 years old. That's why when you turn 50, they want you to go get a colostomy. Yeah, you're going to end up with a colostomy if you have colorectal cancer. No, that means you need to go have, you need to go get scoped. Let's put it that way. When you turn 50, and if you have family history of cancer, boom. If you have a family history of colorectal cancer, you're probably going to start earlier than 50. Males and females, third most common type. Now, males and females, what other thing do you have besides male and female? But they're saying equally, male and female, it's the third most common type of cancer for men and women together. Now, with women, they're going to say, it's for women, they have a different list than men, common cancers. But for men and women together, third most common type of cancer out there that exists. With that being said, again, remember what I said? It's not studied as much. But then nobody likes to get scoped. We don't talk about. I know we have a ribbon for everything. I think my father-in-law, who had leukemia and myeloplastic disease, I think his ribbon was either purple or orange. I can't remember. But breast cancer, of course, is pink, and now they have colors for everything. But I don't know what color colorectal cancer is. You'll have to look that up. But we don't see people doing drives and everybody wearing pink for colorectal cancer, do we? Which is a shame. Liver cancer, it is usually always a primary cancer when it's identified, and that's important to know, right? We need to know that. It's called hepatocellular cancer. When you have patients that have chronic liver diseases, they are more likely to get liver cancers. And when cancer metastasizes, almost all cancers, they really like to go to the liver. But think about what the liver does for us. The liver is a filter for us, and so it kind of catches everything. And therefore, that's why you're going to see that. Hold on just a second here. There we go. Therapeutic pancreacentesis to drain fluid is often happened when you have malignant ascites, which ultimately just means fluid buildup. And that's can happen whenever the body has trauma, and then malignant cells get accumulated and they can fill up the abdominal area or the peritoneum. They'll drain that fluid and then they'll biopsy it. When this happens, it'll always tell you to code the neoplasm first and then the malignant ascites. But don't ever use the malignant ascites as a primary code. So in other words, I think of malignant ascites as we have liver cancer. And remember I told, if you ever skinned your knee and you get that fluid that builds up on the skinning of your knee, that's how your body first starts to treat something wrong, trauma to the body. So what does it do? It builds up that fluid. It sends everything there to go treat that irritant. That's kind of the way I think of malignant ascites, is that fluid builds up around the liver and in the abdomen because there's something messed up with the liver. And but that it's never a primary. Okay. It's always the result of another cancer happening. If you have respiratory or and or intrathoracic organs, you're going to have lung cancer. One of the most common types of cancer is lung cancer. And it's not because people smoke. It is, I think it's just the carcinogenics that we breathe and our lungs get compromised. There's two main types of lung cancer. You have small cell lung cancer and you have non-small cell lung cancer. So instead of calling it large cell, they just say you have small cell lung cancer, which is SCLC, and then you have non-small cell lung cancer. So it's not small. It's not large. It's not small. So I thought that was funny. 85% of the time it's caused by smoking. Now, when we talk about smoking, we don't just mean you physically are a smoker. You're in a household with somebody that smokes, right? It's caused by smoking. Whether you're smoking or you're in direct contact on a daily basis, that is still being inhaled. Most common type is bronchiogenic carcinoma. That's what we see most of the time your diagnosis will be. And then respiratory continued pleural effusion can happen. Malignant pleural effusion, that is the pleural sac that the lung is in. Anytime you have a organ or body part that has repetitive movement. So all of your joints have fluid to keep it moist. Okay, have you ever seen anybody drill something, especially metal, or they're drilling and then they pour water while they're drilling that? Why do they do that? Because friction creates heat, creates fire, all right? So the same thing, our joints, anything that articulates, an articulating joint has fluid and a pleural, like sac type area that keeps that moist. Otherwise it grinds. And that's what ultimately happens with arthritis. The other parts of our body that will have a pleural space and a pleural sac will be organs that move constantly. Now, our brain doesn't really move around, does it? But it does have a protective sac because it jostles around in our brain, in the cranium. However, think of your lungs and your heart. Constant movement all the time, never stops. Remember I was telling you this? How would it prevent this traumatizing? You put lotion on there, right? And then if I do this for an hour and I keep lotion on there, it's probably going to be fine. That's why our lungs and our heart have a pleural cavity, a pleural space. You can have malignant pleural effusion, which means you have a buildup of fluid of malignant cells that surround the heart or the lungs. And you're going to first code the malignancy, then the malignant pleural effusion, if you know what it is, and you probably will. Then we have bone, articular cartilage, and skin. What do we mean by articular cartilage? Well, cartilage is a cushioning for that joint, so we don't have bone on bone, and then we have the fluid in there. So again, when you look at a knee and they say, oh, we need to replace your knee. Why? Because there's no articulating cartilage left. It's worn away. And so it's bone on bone, grinding. It's like grinding your teeth. The most common are going to be BCC, which is basal cell carcinoma, ultimately exposure to the skin, and it doesn't metastasize. It can grow. You do still need to remove that. My husband actually had a spot, and I looked at it. It's very specific the way it looks. It almost looks like a volcano that's already erupted and turned into an island. That's what I think of it. You know, it's kind of like a circle with a deep embedded space, and it doesn't necessarily a complete circle like a ringworm type thing, but it'll be built up kind of, you know, and it has a specific look about it. And I remember telling myself, you know what, I think that's a basal cell carcinoma. You need to go have that looked at. And so we went to our PCP. This was a long time ago. And the PCP looked at it and says, yeah, I'll take it off. I'll biopsy it and we'll see. And it came back. It was a basal cell carcinoma. And he needs to have the rest of it removed. But when they did the biopsy, he pretty much took it all off. But again, it's exposure to the sun. Who gets these? Farmers, people who work out in the sun all the time, professional sunbathers, stuff like that. Squamous cell carcinoma is different at SCC. It's the second most common, again, same reason, but it tends to be on the lips and the ears. You can see, you get it on the nose a lot too. But it likes to have a high metastatic rate. Now, it's a little bit different. It can eventually spread, but that's why I said when you see a person that has a tumor, on a big old tumor, you've seen those, they can still be squamous cell carcinomas and they can eventually go. There was, I think if you've watched The Doctors, is it The Doctors? There's a TV show or something. There was the lady, the blonde lady, and she had that great big squamous cell carcinoma. It was a glandular carcinoma. No, it was squamous cell carcinoma on her neck. And the doctors in LA, which I can't think of what their names are now, but I follow them and look at the treatments they do. They'll show the procedures. They removed that. She waited so long, years and years and years, and eventually now she has cancer in the lung because of that. So, but it also likes to come back in the same area. My dad actually, when my father had one, he had one on his face, and it wasn't very big. I looked at it. He goes, "Yeah, I got to go in. The skin doctor is going to take that off." And I said, "Oh, okay. Well, you know, let me know how it goes." And you know, they biopsied him. That's what it was. And they cut him like this far for that little bitty one. Again, not so much done with basal cell, but with squamous cell, yeah. So, but you can't even see the scar anymore. They did such a good job. But again, when he showed me the picture of what they'd done, it's like, for that little bitty spot, yeah, it'll cut me. And because they want to get all the margins, because it likes to recur and we don't want it to turn into cancer. Continuing with that, malignant melanoma is the skin. We've already talked about that. Really, you need to know that that is the most dangerous skin cancer. And I personally kind of think that it's one of the most dangerous cancers, period, because people don't see it. People don't recognize it. And it doesn't really cause any problems. You know, it's kind of like that silent killer. Oh, I got this dark spot on my arm. Yeah, it's 3 different colors, but it doesn't go anywhere. Well, it's because it's not getting bigger this way, it's getting bigger this way, and then going out throughout the body and causing other kinds of cancer. You know, so in my opinion, melanoma is one of the most dangerous cancers out there, but it's the most dangerous skin cancer, definitely. The things to know about melanoma is that it's asymmetrical. That means that it's my word, it's wonky. It's not perfect, smooth. Remember I told you my husband's basal cell carcinoma kind of looked like an erupted volcano, you know, and it was kind of raised. We know it kind of looks like a crescent moon, a little more than a crescent moon, you know, a little more. And it's easily identifiable, and you look at it and it's like, yeah, it's symmetrical the way it looks. Whereas it's asymmetrical. It's not just a circle. It starts out as a circle, then it has these fingers that go off in little ways, or it's not got pretty borders specifically. The colors, it's not just one color of brown. It's not 2 colors of brown either. It's 4 colors of brown, and usually has a really dark. There's a diameter involved, and they can be very slow growing on the top. But even when you see something tiny on the top, when they identify it, it's really extremely invasive. melanoma likes to go down and spread out with fingers. If you look at pictures of it, it'll go down like a stalk, and then it does this. And that's exactly, it's like it's making a map of everywhere it wants to go. And then it just keeps going. And then the cells break off, because once it goes down, it gets to the into the blood system and the lymphatic system, and just goes throughout the body. Very, very bad. Malignant continuing osteosarcoma. It is the most common bone cancer. The thing about that is it's usually identified between ages 10 to 30, so it's a younger cancer. When it shows up, it likes to show up in the arms, the leg, the extremities, and the pelvis. That's usually where they find it. So there's a knot on the leg of a child. You think, what is that? And then come to find out it's an osteosarcoma. One of the things that makes those different, they don't move. Okay, if there's a knot on your kid, and my granddaughter has a Bible cyst, they call them, that's got another name, but we call them Bible cysts, right, on her wrist. And I said, hey, it's right there, and you need to go have that checked, because it kind of moves, but she's so little that there's not a lot of place to move. And I said, go get that checked and make sure that is a cyst and not a sarcoma. And they did, and they confirmed that's what it was, because they can go drain them. Then we have soft tissue, which is mesothelioma, and you see that advertised on TV, right? Soft tissue is anything that protects an internal organ in it. So mesothelioma likes to go to the lungs. So people that have been exposed to asbestos things. Remember I told you that pleural sac is of the lungs, that's the most common, and asbestos. So you see those lawyers advertising, and I have to laugh because there was one that was being advertised where we lived, and I believe it was up when we were in St. Louis, and the commercial read, have you or someone you loved died of mesothelioma? Are you dead, or someone you love died of mesothelioma? And due to asbestos is what it says, because if it's due to asbestos, then they can sue somebody, is ultimately what they're trying to say. So if you or someone you love have died of mesothelioma due to asbestos, we got money for you. Symptoms, well, pretty much like what you would think. Chest and rib pain, cough, shortness of breath, nodules under the skin that they could feel. And one of the other common signs is a person starts losing weight rapidly and for no reason. Kaposi sarcoma is another type of soft tissue, but what's really interesting about Kaposi sarcoma is it's extremely unique and it's opportunistic. So people that have HIV and they get Kaposi sarcoma, that means that it turns into AIDS, because it's an opportunistic. It took advantage of the person having HIV, and when you get into that portion of coding, when you have an HIV positive patient, they don't have AIDS, but if they get Kaposi sarcoma as a diagnosis, then they're no longer just HIV positive. They now have AIDS, which is B20. So you would code both of those. You can have it in more than one site. And this is where they get those black, you can see pictures, they get the black spots on their skin. And that's what Kaposi sarcoma is. It gets into the lymph nodes in the blood system. And it is coded separately as a primary site when you have Kaposi sarcoma. Ultimately, again, write that down. Kaposi sarcoma is one of the ones that you'll be tested on when they want to make sure that you understand the difference between HIV and having AIDS. They'll say HIV positive patient was diagnosed with Kaposi sarcoma, and then you have to code that. And HIV is what is HIV? I can't remember, but B20 is AIDS. So you're going to code the Kaposi sarcoma, and then you're not going to code them as HIV positive. You're going to code them as a B20, which is AIDS, because Kaposi sarcoma turns HIV into AIDS. And that's another discussion, but you need to write that down, because there's like 15 or 30, I can't remember how many opportunistic diseases that turns HIV into AIDS, but Kaposi sarcoma is one, and there's also a type of pneumonia that is opportunistic that'll do the same thing. Those are the two that are commonly used for testing purposes to see if you understand the guidelines surrounding that. And it is very, very important that you you know that. You don't want to give somebody AIDS if they don't have it, but if they are have Kaposi sarcoma and they have HIV, they now have AIDS. Let's see, moving on, gastrointestinal stromal tumors, which are GISTs, GISTs. This is cancer that develops in the digestive tract that is in the stomach or the small intestine, not the large intestine, the small intestine, because that is a different type of tissue than the large intestine. The absorption of our nutrients are all done in the small intestine, if you didn't know that. It can be benign or malignant, and you always code to primary malignancy when you have this type of cancer. Now let's talk about what happens with the breast and female and male genitourinary cancers. Just a word of advice for testing purposes as well. Men can get breast cancer. Men have breast tissue. They just don't have as much breast tissue as women, right? So again, just because it says male in the documentation, don't think that a male can't get breast cancer. They can. And there's a specific code for men, male breast cancer. Okay. It's not going to be the general code. It's going to ask you if it's male or female. And you're going to think, what? No, it's a very high specificity. So if it's a man that has breast cancer, they can get breast cancer. They do have breast tissue. So for breast cancer, is it going to be infiltrating or invasive? And ductal cancer is the most common, and that is called IDC. That is, my mother had ductal carcinoma, but most women that get cancer have ductal, and that's where she called it milk dud cancer. She goes, "What kind of milk dud cancer do I have?" It's like, no, mother, it was ductal cancer, not milk dud cancer. And we are a very happy, laughy family, and we laughed till we cried on the way home, her and I, driving back from her diagnosis. We knew she had cancer because they saw it, but we didn't know what type of cancer that she had. And so that was, I think we took her oncologist and her surgeon and her family practitioner, who I grew up with. We went to high school together, her family practitioner, took them a little off guard with our laughing and joking. We took it very seriously, but I also think that's another reason, and her doctors think so too, that she did so well with her treatments because of our attitude. Attitude really helps with cancer. Testicular cancer, of course, is only going to happen to men because even though men have breast tissue, women do not have testicular tissue. Prostate cancer usually affects older men. Younger men can get prostate cancer, but they usually get testicular cancer, not prostate cancer. And I joke that God's way of getting even with women going through menopause is giving men having problems with their prostate. That doesn't necessarily mean they get prostate cancer, but it swells up and gives them all kinds of problems. So, and it all happens around the same age. As women start menopause and go through menopause, men start having problems with their prostates. So this happens with age. I joke in lectures that women go through menopause, but we get even with men because their prostates fall off, which they don't, but you want them to fall off. Kidney and bladder cancers can affect both men and women as well. But for the most part, statistics have shown us that it happens between 60 and 70 years of age. So you don't end up seeing kidney and bladder cancers in people unless they're older. Now, that isn't the same as things like cervical cancer and uterine cancer and stuff like that, though. Of course, those are specific to women. So what about other organ cancers like the eyes, the brain, the CNS, thyroid, and endocrine cancers? these are classified as gliomas. That is the most common type of malignant brain cancer. Anything that is starts with a G, or has like meninges and G's in it, tend to be in the brains or the central nervous system, just so you know for your verbiage. And glioma is the most common type of malignant brain cancers. It ends up happening in the glia cells of the central nervous system. Now, don't forget, the central nervous system goes from the brain down to the spinal cord. Okay, so the brain and the spinal cord is involved. You end up with 4 grades. So the because the spinal cord, the central nervous system, breaks the body up, right? Our diaphragm, top and bottom half, you can have it through the spinal cord, which goes past the diaphragm. Brain down past the diaphragm. So again, you can have more grades and levels. The glia cells that you're going to see, or that are going to have cancer, is you can have pilocytic astrocytoma, you can have diffuse astrocytoma, anaplastic astrocytoma, GBM. You can also have oleodendroglioma, which ends up doing glands. Indro is the gland that I'm trying to pronounce. And then you can have ependymoma. Those. Hope they don't try to they don't have to try to transcribe me making funny noises. Continuing thyroid cancer doesn't have an age preference. The types of thyroid cancer that you can have, and now we're only dealing with the thyroid. This is a type of gland, the thyroid gland. You're going to have papillary, follicular, medullary, and anaplastic. So these will be termed in your manual, but those are the types. When we have neuroendocrine tumors, they can be malignant and or benign. So I know some people that have had these type of neuroendocrine tumors that were benign. I don't know anybody personally that's had a malignant. They grow very, very slow, but there's 2 types that you can get. You can get the carcinoid, or you can get pancreatic neuroendocrine. 2 groups of that particular type of cancer. And the reason you don't find them fast is because they're so slow growing. If you end up having a malignant tumor in this area, then what they find is that when they're small, they're benign, but when they're larger, they end up being malignant, and they do metastasize. But when they do metastasize, the most common places they like to go is the lymph nodes, liver, lung, and bone and skin. Okay, so that's, again, how do we know that? Because of the statistics that we've collected as coders. And we don't do the statistics just nationally in the United States. It goes to the World Health Organization, to WHO, and this is a global statistic, not just in the US. But they can tell you which countries have more cancer, certain specific types of cancers, because we report those statistics to WHO, and WHO can say in the UK this type of cancer is more common than in the US, et cetera, et cetera. Malignant, ill-defined secondary and unspecified sites. Now, we've already talked about that, but unspecified sites, this is going to be secondary or cancers that have moved from another place. CCC. Remember, I told you that the numbers get higher after our character, our letter. So if you see a code that has a high number like C7, then it's definitely not a primary cancer. It's going to be a secondary cancer. And then the higher the number, then it's going to get into this unspecified or ill-defined. And they end up being cancers of the lymph nodes, or and C7 9.51 is when you have metastasis to the bone of this type of cancer. And it does like to do that. If we have lymphoid and hematic and related tissue, because that is expanding in the body. If we have a lymphoma, then we have cancer in the lymphatic system two types of lymphatic system cancer. We have Hodgkin's disease, which is HD, and we have non-Hodgkin's lymphoma, which is NHL. Non-Hodgkin's is more common than Hodgkin's lymphoma. And what happens is the cancer goes through the lymphatic system, follows the blood vessels. Remember, I told you they're together. Wherever you have blood vessels, you have lymphatic system. Lymphoma is going to be any organs that contain lymphatic tissue. And that's pertinent too. So as you learn the anatomy of the body, there are some exceptions in ICD with the guidelines. And the reason that is because the lymphatic system goes through the whole body, just like the bones go throughout the whole body. So if you have lymphoma and it's in different or multiple areas, this is not considered metastatic because it's one organ that goes throughout the whole body. But if you have a patient that has no active disease, it can still be considered to have lymphoma, okay? Because they really can't tell if it's out there or not. It's like trying to catch, going out to your creek and trying to catch crawdads in your creek. They're all over the place, right? You may think you got them all, but all you got to do is flip over another rock and there's a crawdad. Now you know I grew up in the Ozarks. Let's see. Leukemia is cancer of the blood cells, but it's white blood cells specifically. It starts in the bone marrow. So they'll go in and they'll do a biopsy of the bone marrow. They'll tap usually the pelvis and pull out those cells, and they'll look at them immediately and be able to tell a lot of times. They will go into the lymphatic system, and because the bone marrow is producing white blood cells, it's going and it's talking to the lymphatic system and helps spilling waste into the lymphatic system. The blood system does that. The spleen, heavy grower of blood cells, as well as the liver, and the central nervous system can be affected. You know, because the central nervous system is right there. You got we always think of the system, you know, we think of our heart, and the vascular system goes throughout the body. Then we have their lymphatic system. And then right next to all of that is the central nervous system, the peripheral nervous system too. So again, all those nerves are right there. You can have acute and chronic, but mostly it's acute. In situ neoplasms, this is abbreviated CIS, but it's pronounced in situ. You have some people that say in situ, but it's in situ. I noticed they say it different in the UK. But this is malignant. It's still malignant, but it doesn't ever leave that original site. It's encapsulated. A lot of people describe it as a jelly bean. So it doesn't like to spread or invade other tissue, which is a very, very good thing. I tell people, man, if you're going to have cancer, malignant cancer, you want cancer in situ. Can it mean that you'll get cancer again? Yeah, you know, you can happen again, but it is easily treated. It's easy to find. It's very, very curable, and it's always an early stage or when you find this. So again, you can get cancer, but it's in situ. Neoplasms of the uncertain behavior. We have polycythemia vera and myeloplastic syndrome. They're not malignant and they're not benign. It's like, well, I thought you had to have either malignant or benign. You do, but these are the ones where they look at them and they say, hey, we've seen this before. We don't know what it's going to do. Is it going to go malignant or is it going to go benign? It's uncertain. And these are the type of ones that do that. They end up being like a syndrome. The pathology is inconclusive. So we can't tell. We know it's not a good thing. Something's happening here, but we don't know which way it's going to tip. It is specifically documented as uncertain behavior. Do not use an uncertain behavior code unless it states it's uncertain behavior. And the thing we need to know about that, and we need to track this statistically, is because it could turn into a malignancy. It's a precursor of malignancy. You are going to look for in your ICD manual, it's going to specifically have a column. We're going to have malignancy first, primary, secondary, benign, cancer in situ, then you get into these uncertain behaviors. And specific codes for that have to have documentation, or you don't use them. Just because you don't know what it's doing in the documentation, that's not the key to use this. The provider will document it. The pathology report will document it as this. The things to look for when you're looking at that will give you indications of growth, neoplasm, and tumor. But then you're looking for that for everything, so it's not really a big deal. Z codes. The Z codes are going to identify, we've already talked about them a little bit, whenever we have a procedure related to a neoplasm. So our patient is having an encounter for chemotherapy. We're having an encounter for radiation. We're having an encounter for chemo or immunotherapy. We're having an encounter to treat a complication of a treatment or the cancer. These are Z codes that tell the story. Why is the patient being seen today? And so no, they'll be associated with treatments, medications, sometimes it's lab values or diagnostic tests that are being done. Why are we having a mammogram? It's a Z code because the patient has a family history of breast cancer. Or why are we doing a mammogram? Because the patient has a personal history of lung cancer. Things like that. Now, we already talked about the sequencing. I went over that first, but here is just some more guidelines or information to flesh that out a little bit. We always code primary malignancy first, unless the treatment is being directed at the secondary. We can have recurrence of a primary malignancy. Now, some people think that you can't have that, but yes, you can. You can have a reoccurrence of a primary malignancy. How do we do this? How do we code it? Well, then you code it as a primary malignancy again. We attempted to remove it, but the malignancy came back. Sometimes you have prime signs and symptoms, and we need to know, is it the primary or the secondary malignancy that is being checked on? That's going to give us the code that we're going to end up coding first. Where is the malignancy being treated directed at? Excuse me, where's the treatment for the malignancy being directed at? Is it the principal diagnosis, the primary lung cancer for Mrs. Brown, or is it the secondary of the brain? Is the patient being admitted for brachytherapy? Okay, then malignancy is the principal site. If we're going to be admitted because we have an obstruction, then neoplasm is coded as the principal diagnosis. Whenever we have complications, that becomes the principal diagnosis, the first one that we list. Because why are they being seen? Because we had a complication. What's the complication of? The cancer. Whenever we have the encounters for the treatments, the therapies, then that Z code for the encounter is being coded first. Can we have more than one type of treatment? Yes, we can. And then it doesn't matter which one gets first. If we have a complication during the admission, so the patient's admitted into the hospital because they had cancer and they developed a complication, then they're coded as a secondary diagnosis. If you have a secondary diagnosis code for the malignancy because of the complication, then you're going to code that second. Previous excised malignancies, Z codes. They no longer are being actively treated for that cancer. Now, you see a lot of debate on this for tamoxifen given for breast cancer because they have breast cancer survivors take tamoxifen for 5 years, but you need to see what your policy is in your facility for that or with your provider, set that with your compliance. But tamoxifen is primarily used to prevent it from coming back. It's not really active treatment, but there's opinions back and forth. So that's kind of a gray area, but you're not going to be tested on that because it is a gray area. Neoplasms, you always still code everything that's active treatment, right? It's not a history if it's actively being treated. What are the influencing factors that are going to give you a Z code? Personal history that we've already went over, family history that we've already went over. If there's an artificial opening, so a person has gastrointestinal cancer and they have a stoma placed, that's an artificial opening. What if we have esophageal and we had to put in a trachea? Prophylactic organ removal, we had bilateral mastectomies because they carried the Braxton gene. Attention to artificial openings, meaning they have an artificial opening, but this is why they're being seen, because we need to address the artificial opening, the stoma. Special screening for, we're going to go in and do a special screening for the Braxton because the patient's mother was had that specific type of cancer and carried the Braxton gene. Now we need to screen to see if you carried as well. And genetic susceptibility too, which would also be the reason we'd screen. Modalities. What are modalities? Well, that just means treatment. So again, surgery, we're going to take out the mass. Chemo, we're going to give it chemicals, drugs to kill it. We're going to radiate it, so we destroy all of that tissue, and we're going to give immunotherapy. We're going to take cells from the body and we're going to tweak them and put them back in. Really, the modalities also are going to depend a lot on where are we treating it? Are we treating brain cancer, or are we treating lung cancer? What grade is it? What stage is the neoplasm? Have we gone from two different sides of the body with the diaphragm being the middle point? And what's the health of the patient? If you have a 30-year-old with breast cancer, the modality is going to be different. The plan of care is going to be different than a person who's 80 years old with breast cancer, right? The treatments are going to be on a 30-year-old that's going to have a bilateral mastectomy is going to probably have a reconstruction surgery at the time of the mastectomies versus an 80-year-old patient. Take those babies off. We don't need to worry about it anymore. All right. Procedures, the PCS codes, these are always going to be in the med-surg area. Remember, that's the largest area, always going to start with an O for a PCS code. And there may be also treatments that are in the, not the med-surg, but in radiation therapy. We could be doing placement. Maybe we did bilateral mastectomies and we're doing reconstruction and we're placing implants for the breast. And we are probably administering chemo and other types of treatments. Chemotherapy, cancer-killing drugs, we can give it more than one way. Intravenously, most common. Orally, we take the medication. They can give subcutaneous, intramuscular, and intrathecally. Whenever they give chemo, a lot of times they'll put a port in. Radiation, the high energy beam, we're going to zap them. We're going to radiate them. Palliative care, we're just going to keep them comfortable. You know, remember when we said they're disseminated, their body's full of cancer, and because of their age, they've decided not to have any other treatment. So we're giving them palliative care, and usually they'll go on hospice. Brachytherapy is radioactive material that we place near the cancer. This is very commonly done with prostate care. They'll put little radioactive seeds into the prostate that radiates the prostate. And this is really neat. You can see images of that. You can go in and look at that. And there's these little bitty, they look like little rice seeds in there. Endoscopic treatments where we go in and we do a scope and we remove polyps, and small polyps, even foreign bodies, or we control bleeding. Biopsies, you're always going to get a biopsy with any type of cancer. The thing about, you think, well, what about leukemia? You can't biopsy the blood, but remember, it's produced by the bone marrow. They'll go in and do a bone marrow biopsy. They can either do surgically or they'll do a core biopsy. They'll do a punch biopsy, depending. My father-in-law, who had leukemia, had biopsies done of his hip several times, and it was like a punch biopsy. They just did it. The one oncologist did it in the office. They just numbed you up, stuck that big giant bore needle in there, pounded it to get into the bone marrow, pulled it out, And then he literally looked at the microscope right there and told him. So again, there's several ways to do that. Know that core biopsy and fine needle aspiration, two different things. When you've had a biopsy, you're probably going to get a, there'll be a procedure report done. It may or may not have been in the OR. Like I said, my father-in-law, they did it in the office, in the oncology's office, but you'll always probably get a path report as well. They can do at the same time as the operative procedure. They'll do this a lot of time when they do Mohs surgery. That's what Mohs surgery is. We shave off a section, we quadrant it off, we look, and if there is cancer cells in all 4 quadrants of that shaved layer, we go into a deeper layer. And then if you only see it in 2 quadrants, then we don't have to shave. We only take out of the 2 quadrants, and then we go deeper, and we only see it in 1 quadrant, we go deeper, and then we just keep going till we don't see any cancer cells anymore. That's Mohs surgery. So what are the types of surgery? Well, preventative or prophylactic, right? We're going to remove whatever has the tumor or the cancer. We need to stage it. There's also debulking, meaning we just need to make it smaller because it's causing constraint. And we have restorative or reconstruction surgery. So if we have something taken, let's say my father had the cancer, and if it was melanoma, they would have taken a massive hunk of his face, and then they would have created a flap and done reconstructive surgery at the same time. Prophylactic surgery, you're going to see Z codes to show that we removed something and it was prophylactically. And that is it, guys. Now, I know this was a lot of information. I really enjoy this. I know, I don't even know what time it is, but we've probably talked for a very long time. Take a deep breath. And remember, you got this. This is something that you will be tested on. You are going to code cancer out in the real world no matter what, because it just touches everybody's life. You'd be really hard pressed to find anybody that doesn't know somebody that's been affected by cancer. And it's very important. You know, go back and think of my mother with breast cancer and how her treatment was changed by what we as coders code. That's huge, guys. That is such a big deal. And that's why we want to make sure that we always get it right when we code. And that's why the guidelines are in place to tell us how to code properly and to the highest specificities. That's why you have exceptions to the rule, like with anemia and cancer, stuff like that. So we're collecting statistics. It's much more bigger than what we're doing. And so as long as you remember that, and don't worry, it's intimidating now, but it gets easier and easier because these guidelines don't change. You know, they may tweak them from time to time, but it's so repetitive, and before you know it, you got it under your belt, and it won't take long, and you'll have it. Let me just look real quick. We have a question. So primary is brain cancer. Simply, what is the encounter is chemotherapy and radiation therapy combined treatment? You can have radiation and chemotherapy combined at the same time. They do the treatments at the same time, and there's codes for that. I don't know how common that is. I think it really depends. You know, for example, my mother went through a year of chemo, had her mastectomy. She went through 6 months of her chemo. They did the mastectomies. Then she went through 6 more months of chemo, and then they said they would start radiation. You know, and protocol is different for all different types of cancer because of the coding that we do. We know what treatments work best with what type of cancers, and sometimes they're done together. So that's why you'll see those codes. Now, brain cancer. Brain cancer is only the primary listed, meaning primary means we list it first in the sequencing. If it is the cancer being treated. But if it is lung cancer that metastasized to the brain, this is primary, this is secondary, okay? So I think we went over that. pretty good. And again, if you have any questions, just ask them in the student support area. We'll be more than happy to answer them for you. And if you're seeing us live on Facebook or YouTube, don't forget to like and subscribe and go to the CCO Club to ask your questions. All right. Bye, guys.